Assalamu alaikum. My name is Irfan. I am a consultant anesthesiologist at Al Khan University Hospital. I am honored to take part in this online course organized by PSA Karachi chapter. My topic of presentation is Guidelines on Airway Management in Adult COVID 19 Patients. Before starting a service of attending rush calls in COVID 19 patients, we need to focus in preparing three important areas: preparation of intubation bag, organizing a team for attending rush calls, and developing a standardized protocol or checklist. The intubation box or kit should ideally contain three things. Number one is personal protective equipments for healthcare providers, equipments and adjuvants for airway management, drugs for intubation and resuscitation. Multiple bags should be prepared in advance to save time in attending a rush call on a COVID patient. This important topic of PPEs has been discussed by my colleagues, so I will skip this slide. Equipments needed in that bag for airway management include endotracheal tube of adult size 7 and 8, airway adjuvants like tooth guard, oropharyngeal airways, bougie, and stylet. Second generation supraglottic airway devices in case we failed in intubation. Lubrication and tube fixation band and tube clamp. Tube clamp is used for clamping the endotracheal tube before any planned disconnection. Syringe for cuff inflation. Ideally, cuff pressure should be 5 cm above the peak inspiratory pressure. Mapleson C circuit with HME filter at patient's end. Intubation should ideally be done with video laryngoscope, either with disposable blade or Magra video laryngoscope. Drugs in that bag include drugs for intubation and drugs for resuscitation. We recommend co-induction with propofol and ketamine, while we advise lidocaine for blunting the airway reflexes, succinylcholine for muscle relaxant. Resuscit- Resuscitation drugs include phenylephrine and epinephrine for counteracting any post-procedure hypotension. One of the one of the important aspects is the formation of intubation team. A dedicated separate team for intubation should be constituted in an active setup dealing with increased number of COVID-19 patients. Two teams, each having 4 members, rotating in AM and PM duties for a whole week, then taking rest for the next 2 weeks before returning to work again. In this type of setup, you need 6 teams plus one team as a backup team to run effectively a rush call service. An intubation team should at least consist of 4 members: lead person, anesthesia technician, nurse, and facilitator. Lead person should ideally be an anesthesiologist. Alternatively, ER physician or intensivist can play this role, provided they have adequate experience in dealing with airway emergencies. Anesthesia technicians play a critical role in helping during intubation. Nurse is responsible for giving IV drugs and monitoring the vitals. Facilitator is the only person that is without PPEs and he remain outside the negative pressure room. He will help us in providing backup and support if need arise. Team member should not include any person with age greater than 60 years, pregnant, or suffering from chronic disease requiring immunosuppressant or high dose of steroids. Inclusion should be on a voluntary basis, as fear can sometimes lead to mishaps. Avoid crash induction in COVID 19 patients. Reasonable time should be available for donning and doffing of healthcare providers before going into the room. This high risk aerosol generating procedure should ideally be undertaken in a negative pressure room or room having HEPA filters. Alternatively, a plastic box or a transparent sheet can be used in resource limited setups. Prior to intubation, you need to apply monitoring as per ASA standards. Confirm and secure intravenous access before entering into that negative pressure room. Once you enter, do a quick assessment of airway using Macocha score. Confirm NPO status and loose dentures from patient himself if is in full conscious state or with the attending nurse. Remember, take minimum equipments in the room. Prepare endotracheal tube and drugs outside the room and hand over to the concerned team members, that is nurse, with clear instruction. About Macocha score, it consists of 7 components. Each component has a certain score. If sum of that score is greater than 2, then it predicts difficulty in intubation. So plan accordingly. Intubation technique should ideally be a rapid sequence technique without bag mask ventilation. Pre-oxygenation for 3 to 5 minutes with low flows and tight seal. If bag mask ventilation is needed before intubation, then use two hands techniques with low tidal breath as shown in this figure. Avoid taking keys, pagers, badges and phones in patient's room. Effective closed loop communication among the team members. Donning and doffing is recommended in a designated separate area. Documentation of the procedure should ideally be done only after doffing. We recommend taking full body shower after every intubation in COVID 19 suspected or confirmed case. We highly recommend simulation drills for healthcare providers in donning and doffing. Don't rush for intubation without proper PPEs. Remember, this is not a training scenario. First attempt should be your best attempt for intubation. Avoid cuffing or straining during intubation. Auscultation after ETT placement is neither advisable nor possible with intact PPEs. Avoid Sitka disconnection and if needed, clamp the tube before any disconnection. Avoid open suctioning as it will disseminate aerosols and can cause cuffing in light plane. Discard stylet or use laryngoscopy blade immediately after use. The whole PSA guideline on airway management in COVID 19 patient can be summarized in that single word rapid. R stand for reliable technique, A for anesthetist with airway experience, P for preparation of drugs and ETT in advance, I for intervene early for intubation, D is for donning and doffing for the safety of staff. We recommend using hard copy of this checklist during each intubation. This checklist consists of preparation and planning, donning and doffing, and finally induction technique. Anticipate difficult situations and plan preemptively in dealing such scenarios. Counter agitation and apprehension in COVID 19 patients with IV midazolam before proceeding for intubation. Use supraglottic airway devices, preferably iGel, for failed intubation attempts. Keep another anesthetist on standby for possible backup support in can't intubate and can't ventilate scenarios. Extubation, like intubation, is also an aerosol generating procedure. Bridging measures like non invasive ventilation and high flow nasal oxygenation immediately after extubation are relatively contraindicated in COVID 19 patients. Similarly, use of supraglottic airway devices is also controversial. Extubation of COVID 19 patients in operation theaters is slightly different as compared to one in ICU. Drugs like dexmedetomidine, lidocaine, and remifentanil are helpful in elevating coughing and straining response of patients on extubation. These drugs will not help in ICU because of their adverse effect on chronically ventilated patients. Following strategies have been used for extubation in resource limited setups, like use of plastic box on extubation and use of transparent sheet with a slit opening for passage of ETT with pilot balloon. This opening will be closed using adhesive and the whole sheet with ETT will be removed on extubation, like shown in this figure. Remember, the aim is to extubate smoothly without coughing and straining. Avoid suctioning after extubation. Immediately place face mask using two-hand technique for maintaining tight seal. Avoid using CPAP on extubation. If encounter laryngospasm on extubation, use pharmacological intervention only. Once stable, place a surgical face mask and low flow oxygen via nasal cannula. With this slide, I will end my presentation. Thank you.